listed here for you, but you may be wondering why we are focusing on this tool. The Center for Effective Practice does amazing work, and if you haven't visited their website and looked at the resources available there, it's a really must-do activity, high value and worth the investment of your time. We all need more help to deliver evidence-based care in our busy work days. And the tool you're about to hear about today, I think, will really help us do that. It's also a chance for us to understand practice across the continuum, and for us in SGS, in Specialized Geriatric Services, to understand better how primary care is working with and helping older adults, especially older adults living with frailty. The goals of the system are really to integrate care and to bring services closer together, and to understand each other's practices is a good starting point for that. So I think today's learning session will really help us achieve that. I'd like to introduce our speakers. We're very fortunate to have three experts here with us today. Dr. Amy Freedman is a family physician at St. Michael's Academic Family Health Team and the physician lead for its home visit outreach team. She also practices in long-term care and in supportive housing at Baycrest. Dr. Freedman is an assistant professor in the Department of Family and Community Medicine at the University of Toronto. She's joined by Lorna MacDougall, is a primary care nurse practitioner at St. Michael's Academic Family Health Team and is the NP co-lead for their home visit program for homebound older adults. She holds an adjunct clinical appointment at the Lawrence Bloomberg School of Nursing at the U of T. And Makayla Gomes is with the Center for Effective Practice, where she is their clinical design specialist for the Knowledge Translation in Primary Care Initiative. She engages primary care providers, system stakeholders, and persons with lived experience to ensure that CEP content and tool development most effectively addresses the evidence to practice gaps in primary care. Please join me in welcoming our three speakers, and I'll turn it over to Dr. Freedman to share her slides.
So sorry, every time it's new.
No worries.
Okay, is that good?
Perfect.
Okay, perfect.
Okay, great. So I'm going to start us off for today. Like in the introduction was said, I am Makayla Gomes. I'm from the Center for Effective Practice. So before we get into our presentation today, we just want to thank everyone so much for taking time out of their busy days and their lunch hours to be here with us today to go through our Preventive Care for Older People tool, or PCOP, as we're going to be referring to it throughout the presentation. So we're really excited to be here with you all, and also very grateful to our hosts for letting us share this tool with you today. So Dr. Freedman, NP, Lorna MacDougall, and I have no significant conflict of interest to report, but in relation to this work, I am a salaried staff member for the Center of Effective Practice, and Dr. Freedman had received an honorarium from CEP for her involvement in this work. So just a little bit about the Center for Effective Practice. For those who aren't familiar, CEP was established in 2004 and is one of the leading independent healthcare behavior change partners in Canada, with a mission of closing the gap between evidence and practice. And we do this by developing trusted evidence-based tools, resources, and programs to ensure that healthcare providers have the information that they need to deliver high-quality care. So we saw the learning objectives briefly in the introduction, but I can just read through them really quickly. So our first one is going to be to implement best practices in evidence-based screening and preventive care for older adults using a novel EMR tool, to use clinical decision support embedded within the tool to manage complex conditions in older adults, and to promote coordinated team-based care in caring for older adults through the implementation of this tool. So what is the gap in practice, and why do we do this work? So it's evident that Canada's aging population have become increasingly complex, and there are various practice guidelines out there and competing primary care needs. So given this, we identified a need for streamlined approaches, such as the Rourke Baby Record, that serves as a preventive guide for clinicians caring for infants and young children, Greg Health Record, which is a health promotion guide for clinicians caring for children and adolescents, and the Preventive Care Checklist form that provides recommendations to clinicians caring for adults during period health examinations. So all of which have become widely used knowledge mobilization tools. So our specific goal essentially with PCOP is to simplify and standardize preventive care for older adults, particularly those with multiple complex conditions. So here is just a screenshot of the CEP website. So both the TELUS PS Suite EMR tool and the PDF version of the PCOP tool can be freely accessed through the CEP website under the clinical tools page that's shown here. And if you don't use TELUS, like I mentioned, the PDF version of the tool can also be freely downloaded and then uploaded into other EMR systems. So we go to clinical tools, and there you access the PCOP tools with some more information about the tools on our details page, like you can also see here. So for today's purposes, given that many of you don't use TELUS, we'll be showing you the vendor agnostic PDF version of the tool with you all, but also happy to answer questions about the TELUS EMR version as well during that Q&A at the end. Okay, so now we're going to quickly go through a rundown of our tool development process before we get into the tool itself. So this image here provides an overview of our tool development process that was used for this PCOP tool. So as you can see, the process is divided into two main sections. So we have evidence collection and needs assessment, and then concept development and prototyping with input from various groups throughout. So all the evidence gathered for this tool was guided by our scope, preventive care for older adults 65 and older. And this tool was based on our evidence base composed of guidelines such as the Canadian Coalition for Seniors Mental Health, the Canadian Task Force on Preventative Healthcare, and many more, alongside guidance from Health Canada and Ontario Health. So our full list of references is also available on our site and linked within the tools. So initially, CEP worked with a prototype of the tool brought to us by our clinical leads, Amy and Lorna from Unity Health. And they had worked on this tool with a couple medical residents who were previously based at Unity Health as well. So to expand the evidence base, a member of CEP's information services team then did a comprehensive literature search to locate the most up-to-date, so within the last 5 years, Canadian guidelines in the various topic areas. And when necessary, we used US and international guidelines. And then all these guidelines were appraised using the Rapid Agree 2, which requires that the guideline employ systematic methods to search for evidence, and that there be an explicit link between the recommendations and supporting evidence. For the immunization and cancer screening sections, we went directly to the most current Ontario guidance since the PCOP tool is Ontario-based. And then CEP then closely worked with our clinical leads. And we also received feedback on various iterations of the tool from expert reviewers, including Dr. Moore and Dr. Warshofsky from the Office of the Chief Medical Officer of Health. And in addition to that, we also conducted usability sessions with family physicians and nurse practitioners to get even more feedback on the tool. And then finally, the final version of the tool was then completed by our core CEP team, our Unity Health clinical leads, our EMR developer, Lisa Miller, also based at Unity Health, and then a graphic designer for our PDF version. And that is in a quick nutshell how the tool came to be. So I'm now going to pass it over to, I think, Lorna, who will take us through the next few slides.
Thank you, Makayla. So we're going to focus on now the practicalities of using the PCOP tool. And I'm hoping that you might have downloaded it from either the CEP or the website or the RGP website so that you can follow along, but there will be screenshots as we go. We're excited about this form because we think it simplifies preventative care for older adults. We're excited to complete the lifespan of preventative care tools, and we are delighted with the embedded clinical decision support that's available in the tool. So we see 3 ways to use it. The full form could be used as part of a preventive healthcare visit booked with your patient. It could be used opportunistically and divided into several visits. And it could be used as a reference on the electronic chart or print out as a PDF, because we have a lot of embedded information, as we'll show you. Next slide, please. So why do a periodic preventative health visit? The Canadian Task Force on Preventive Healthcare actually kind of tossed out the annual physical exam for a lot of asymptomatic adults, saying that it is not effective and may result in harm. However, they also said that it is recommended for older adults because it actually has a benefit. So a meta-analysis of 19 trials on periodic preventative health visits among people older than 65 indicated a decrease in mortality and an increase in their likelihood of living independently in the community. Next slide. And just also related to that, the difference between, let me highlight the difference between annual checkup is that it's sort of a head-to-toe assessment, and there's not, in the end, a lot of evidence for it. But the periodic health review is an evidence-based screening that that is now recommended. So this just gives you the structure of the tool. There are various sections, and we're going to look at it in a second, but these are the sections. It's good. And then next slide. And we intentionally designed it for team implementation. Our team, we have RNs and PMD, we have social work and pharmacy. We don't have physio and OT. We do have a dietitian. But, you know, it can be tailored to your team. The key seems to be booking and also people's enthusiasm. We have booked it with our clerical. Our clerical will book the PCOP for RNs 30 minutes ahead of time for the health behavior section, physical exam, vital signs, which might include postural hypertension, blood pressures, immunizations. And then the nurse practitioner, MD, has 30 minutes to get through the evidence-based review, the exam, and investigations. We would highlight that social work would be experts at advanced care planning, social isolation, low income, elder abuse, substance use, and weighing in on depression, anxiety. Pharmacy, we ask pharmacy for a med review in a patient who has the three Fs, falls, pharmacy, little joke there, and frailty. So that's a trigger for getting a med review. And physio, OT, could do what they do best, and as well with the dietitian. We have local buttons on our form, and we have very enthusiastic nurses. So let's put it in the context of a typical patient. We're just going to highlight this person for context. Let's say you have a patient, Marie. She's 82 years old. She lives alone in an apartment nearby, Toronto Community Housing, which tells you she's low income. And she's recently discharged from acute care for another COPD exacerbation. She has a past medical history of COPD, stable angina, hypertension, recurrent BPV/vertigo, type 2 diabetes. So she has a lot going on, and she's going to be in and out of the primary care office fairly often. And as well, she has 2 children. She lives they live out of town, and she's a former smoker. So, you know, for her, we want to highlight here equity. For her, for Marie, she probably comes in a lot and gets a lot of putting out fires kind of care, where your other 80-year-old person who is going to Pilates and has grandchildren all around her and takes classes. That lady, let's call her Jan, she comes in and she's asking for a periodic health review. So she gets screened. And our Marie doesn't get adequate screening because you're always putting out fires. So what we hope is that this form will help people deliver preventive screening in an equitable manner, recognizing that some of your patients who are disadvantaged or marginalized or complex are often underscreened, and then that puts them at higher risk for developing or exacerbating chronic conditions. This strategies to support culturally safe patient-centered screening is really important to us. It highlights that the patient is in charge, that the concerns that are raised are the patient's concerns, and that there are different strategies for cultural safety. Some, especially Indigenous patients, may want to have supportive individuals with them for their visit. And there are other cultural things that are really important for us to be aware of. The current concerns box there is to highlight that you ask the patient, what are your current concerns at the start of your visit? Again, the relationship with your parent and shared decision-making, considering the patient's values and their goals of care, are really important. Next slide. So the beginning, now we're starting to look at the beginning of the tool. This is the health behavior section. And an RN can do this, an MD, NP can do this, pretty much anyone with can do this. But we wanted to show you that the arrows are pointing to additional information. In our Tell Us EMR form, we hover and up pops these information boxes. On the PDF, you can look, you have to look to page 3 and 4 for further information to see these information boxes. So here's the embedded clinical decision-making support. Physical activity, you can see there. I won't review it, but you can see there. And advanced care planning. We are excited about this. We are encouraging people. The most important thing is to figure out who the substitute decision maker is. The law prescribes who the SDM is in the hierarchy, and sometimes people appoint a POA to jump over that, the law and the hierarchy. So, but it's important for primary care, you see, to document the name and contact information of that person and to encourage patients to express their values and wishes to that person. When appropriate, we complete a DNR form and advise the patients to keep it visibly displayed at home for the EMS people. Now turning over to Amy.
Yeah, so the next section of the tool is what we call the evidence-based clinical geriatric review. And here we've gone through several geriatric syndromes, and we've included what the evidence is for screening or against routine screening. And as many of you, I'm sure, have heard, primary care is, family physicians now right now are very overworked, and the demands are very high. And so that when people go through this tool, sometimes I think they're actually quite relieved to see that there isn't evidence for screening for many of these conditions. And so what we're emphasizing here is targeted screening, to only screen those where there's evidence or where there's evidence for screening with risk factors. So you'll see here in our patient, she does have low vision, and so there's evidence to screen for her vision. She's not presenting with cognitive impairment and any cognitive concerns or functional decline, so the guidelines are not to screen her. In contrast, if you were to hover over this information button by depression or to click to look at the end notes, she does have several risk factors for depression. So she's socially isolated, she's had a recent physical illness and discharge from hospital, and she's economically disadvantaged. And so the tool points the user to several screening tools for depression. So the PHQ-9 or the GDS, and it gives you also in the information point the cutoff for when you know that's a significant finding. The fall prevention, I think, is probably the most compelling section for me of this tool. You know, in primary care, we see many patients who fall, and I think we're good at assessing and treating injuries, but not necessarily in figuring out why the patient has had a fall or in preventing for future falls. And when we look at falls guidelines, they're very comprehensive and very hard to implement in primary care. It's hard to know where to start. So we've tried to distill the World Falls Guidelines into a series of sort of digestible pieces. So the tool encourages you to ask all patients over 65, have you had a fall in the last year? And if the answer is yes, in the TELUS form, you'll see a drop down, but here you'll see several options to assess the fall severity. So has the patient had an injury? Have they had more than 2 falls? Are they frail? Were they unable to get up? Did they lose consciousness? So in our patient's case, we think she is frail, so we've checked yes. And that indicates that she's had a severe fall or a high-risk fall. And the recommendation for those patients is to offer an interdisciplinary fall assessment. So either a day hospital or a falls program or a geriatric assessment. Now, we know that those services are often hard to access, or there's a long wait to access them, or some patients decline. And so what we've highlighted in the tool is what we feel are the most important elements of a multi-domain intervention and things you can implement in the family practice office. So a gait and balance assessment, a referral for a vision check, a medication review, perhaps with your pharmacist if your team has one, or to the community pharmacist, an assessment of their footwear and their feet, an assessment of bone health, which I'll show you, assessing postural hypotension, and referring for an OT for a home safety assessment. And in our local tool, we've put a button to link with OHIP covered physio resources and a button to link to Ontario Health at Home for an OT assessment at home. And if the patient had had none of the above, there's advice on fall prevention and exercise. For the physical exam section, we've only highlighted those maneuvers for which there's good evidence. So you'll see there's good evidence to do a sitting blood pressure in all older adults and to do a resting heart rate, which is essentially a screen for AFib. And we've put a notation that postural blood pressure should be done in people who have had a fall or at risk of falling. And the information button or the footnote defines what orthostatic hypotension is, because a lot of times people do these maneuvers and they don't know what's significant. And we've highlighted height because of the importance of a loss in height in older adults. And then under that section is an open box. So the clinician will decide what elements of the physical exam are important for them to do based on the patient's clinical presentation. The next section is what we call investigations or screening. And we've divided it into patients 65 to 74 and patients over 75. And in the TELUS EMR version, it's quite lovely in that you only see the section based on your patient's age. So if my patient was 80, I would only see the recommendations for her age. And the guidelines go through where there's evidence to screen for these conditions and where there isn't evidence. And we've highlighted here to show you that if you were to look at the footnote for the blood pressure section, you would have a list of targeted blood pressures for threshold to treat and what the target should be. Because of course, these are things that are very hard to track in primary care. There are many guidelines and many conditions. So we've put this in as an easy reference. And we've also put the caveat as to when you would use caution or when close blood pressure lowering would be contraindicated. The other investigations you'll see at the top here are cancer screening investigations, and these are taken directly from the Canadian Task Force. And you'll see, of course, that for patients over 75, either screening is not recommended or it's based on a conversation with the patient, taking into account their values and preferences. And we've put here, you see that little talking head, we call it talking point. And we've put these talking points based on the literature on explaining how you tell patients why you're going to stop cancer screening. And these are phrases that have been found to be most acceptable to patients or most preferred by patients, because a lot of times our conversations with people over 75 are actually about why we're not recommending screening for these cancers. And lastly, for fragility fractures, we've put a link to the Canadian Task Force guidelines for women over 65. And we've adopted the Canadian Task Force framework to do a risk assessment first strategy without a BMD, and then to assess whether a BMD is necessary. We've also put a link to the Too Fit to Fracture guidelines by Osteoporosis Canada for specific exercise recommendations, because we know that we often recommend strengthening and balance training for our patients, but we don't always know what exercises to tell them to do. And so this is a readily available resource. Finally, we've put the guidelines for immunizations here. And as we know, these are rapidly changing. So sometimes we've written just to consult local guidelines. But in the case of Prevnar 20, we have included in the footnote or in the drop-down menu who should be getting Prevnar 20 and you know, how this relates to people who have had Pneumovax or Prevnar 13, again, because the guidelines are complicated and new, and so it provides an easily accessible reference. And finally, the idea of this tool is that as the clinician's been going through it, they've been recording their assessment and plan in the last section. And at the end of the visit is a time to go over what you found and what you're recommending with the patient and develop a shared plan with them. This just shows you a flash of how those information points look as endnotes. And we're going to have time for questions, but we wanted to first give a big thank you to the other members of the CEP team who were instrumental in developing this tool: Gina Bayumi, Ellen Talchinsky, and Lindsay Bevan. Lindsay Miller was our brilliant IT specialist who developed the EMR tool. To thank the family physicians and nurse practitioners who piloted this tool and gave their reviews on the tool. And finally, to give a special acknowledgement to Serena Dai and Annie Chung, who are care of the elderly physicians, who developed the early prototypes for this tool as part of their care of the elderly fellowship through Baycrest and the University of Toronto. Thank you.
Wonderful. Thank you so much for this really engaging presentation on such a wonderful tool. We've got time for questions now, and I can see somebody's already commented about, you know, guidelines go out of date very quickly, and wonderful to, specifically the cervical cancer screening guidelines, having just recently changed as of March 1st. And great that Lorna's already responded to say that you've got a plan for updating the form on an ongoing basis. That's so helpful and so critical. You put together such a beautiful holistic tool of you know, all of the things that need to be considered in the care of older adults. And the fact that you've also thought of an ongoing plan is just quite exceptional. There's a comment about this is a fantastic tool. I love that they're embedded links to important resources. If you have questions, please feel free to raise your hands or just put comments or questions in the chat box, and we'll engage our wonderful presenters on any questions you have.
I'll just comment, it's one of the reasons why we're so happy this tool has landed with the CEP, because they're really the experts on evidence dissemination. And so the hope is that the tool will be updated periodically to incorporate new guidelines.
Fantastic. You know, I have a question that comes to mind while people are percolating and thinking about what they might want to ask. You know, it's Nowadays, people really want to get engaged in their care, especially care partners. I'm wondering if when you're using this tool, if people have noticed that you're following a tool, or do you sort of engage them in any way, or is there any advice on how to engage them in the fact that you're using this evidence-based tool? Or do they even ask about the tool, or if they can have some pointers or highlights about it?
I mean, I think we're in the early days of using it, but I think people appreciate the time. You know, so I've had people that I see all the time for chronic diseases where I'm saying to them, you know what, I want you to come back for a longer visit. And I'm uncovering information about patients that I know well and I see all the time, but I'm seeing the gaps in practice. So, you know, for example, just last week, I had a woman in her mid-80s who was in with her husband, and I realized I had never actually asked them formally about who her substitute decision maker would be. And both she and her husband did not want the other to be their substitute decision makers. They wanted one of their 4 children to be that person. And so then it brought up a whole conversation around assigning power of attorney for personal care. Had I not gone through this tool, and had I not had her husband there too, you know, it was relevant. He's also my patient. It applied to his care as well. And so it was a very fruitful discussion, and one which probably I wouldn't have uncovered had I not had the 2 of them together and had this time to go through it carefully.
That's a great example of how useful the tool is, right? To actually hit points that are important. And sometimes, you know, not uncovered because there's little time sometimes, and you've got to focus on the conditions themselves versus, you know, some of these other important aspects of care. Any questions from our audience, from our participants? What are you thinking of as you think about using this tool, or sharing information about this tool to others who you know might be using it? Dr. Liu?
Thanks so much to all of our presenters. This is a fantastic tool. I really appreciate how thoughtfully you put together the resources that people need to take the next step after reading the initial statement or the initial screening topic. You mentioned that sometimes it's difficult to convince people that you're following the evidence and the guidelines when you don't screen, and that there are some people that are very concerned and have been used to having the screening and expect it to continue. And sometimes I think that we as specialists in geriatrics may not, number one, may not be as familiar with the evidence for prevention. And we also see a skewed population where maybe they have more of those additional risk factors, and we would tend to be doing a little bit, maybe more than what the guidelines would suggest for a general, otherwise relatively well older adult. Is there a tension there between what the specialists are recommending and what you see in your practice? Like, are we sometimes undermining a long conversation that you've had with your patients when you send them to us, and then we end up ordering that extra BMD or other screening tests?
So, I mean, I don't think it's so much the geriatricians, to be honest. I think the geriatricians are more sensitive to these issues, but we have these struggles all the time. Particularly, I find, you know, I have a patient where I stopped her statin, the cardiologist restarted it, she and I talked again, it got restarted, and then they added an SGLT2 inhibitor, you know, so I think these are important conversations. And I think for sure that many specialists are following disease-based guidelines and not necessarily looking at how they apply to patients who are frail or older. So yeah, I don't think the geriatricians are so much culprits as the subspecialists. And it's really having, it's all about having a conversation with the patient. And I find that, in my patient where the specialist keeps starting meds, we go over it together. Like, this is what the benefits of this would be. This is what the risks are. This is how I would see this applying to you.
And we also would, especially when you're doing home visits, we see the context of how the patients are actually managing to take or not take their medications. And we have seen candy dishes full of medications. So for example, and we can see in home visits, but also in the clinic, the burden of some of these guidelines that are just indiscriminately applied without taking in the context of the patient's situation.
Dr. Lou, is your hand still up?
Yeah. I have another question, if I may. So thanks for highlighting that you can use this tool amongst team members and share the questions. And you also mentioned some of the timelines, 30 minutes, 30 minutes. So I was struck by that kind of time investment in a primary care practice. Can you share with us what your typical appointment length is with your older patients, especially the ones with frailty? And how the other team members' schedule works with your schedule?
Yeah, so I think most typical visits in primary care are 15 minutes. And so obviously there's a limited amount you can get done. Sometimes with my frail patients, I will book longer intentionally, but that's why we're booking these, oftentimes in our electronic medical record, there are what we call appointment types. And so, so a physical, what we call a physical, but which is essentially a targeted preventive care visit for an adult under 65 is booked half an hour with the family doc and 15 minutes with the nurse. And it's booked sequentially. So the patient sees the nurse first, and then the family physician or the nurse practitioner. And so what we've done in our practice is we've changed that so that the initial visit with the RN is half an hour and the visit with the physician is half an hour. And, sometimes I can't get it all done in half an hour and sometimes I can. It may mean that I have to bring the person back, but within the context of primary care, it's not that feasible to book longer than half an hour because of the need to keep your access for other patients. In a home-based setting, I do home visits, I can take longer. But we're also encouraging people to think about the fact this tool doesn't need to be implemented in one visit. And so I have patients who, even if I want to book them half an hour, they may no-show. And I know that I'll only implement these maneuvers if I can integrate them into their regular care. So in those cases, I might try to do a little bit of a chunk at each visit.
Excellent practical advice. Thank you very much. There's some questions and comments coming in. One of them is, has there been any feedback from MDs without team support? And also comment that it's excellent tool and presentation.
Yeah, so that's a good question. We haven't heard that yet. I do know that when they did the usability testing, they showed it to physicians working in a variety of settings. And even with the early prototypes, we showed it to physicians in various settings. And my assumption would be that for those people, it would probably need to be implemented over the course of a few visits. But what we're encouraging people to use this is adapt to the team that you have. So I've heard of family doctors in the community who even have their admin person for some patients doing blood pressures or weights with automated cuffs and systems. So really to adapt it to what you have.
That's an important point too, right? Always adapting to what you have. Yeah, do it in small pieces as time permits. I see an interesting comment here, but great tool. I'll share it with my colleagues here in Quebec. There's no mention there about whether the tool would be needed in French, but I'll just pose the question. I know you've just launched this, but any plans, since you've already got a plan to update, any plans on translating to French?
I would say the main thing always is that we're obviously always looking for ways to explore funding to be able to expand our tools. So I think it might kind of come down to that. Also, the need maybe for French tools. This is an Ontario-based tool, just given because the funding comes from the Ministry of Health. So that's also something that we have to keep in mind. So I assume that would have to be an external source of funding. So potentially conversations would kind of have to be had to access that, but definitely an important point.
Okay, so if people do maybe have a need for French, they should reach out to you just to pose the question.
Yeah, we would love to
address the
hear.
need. Yeah.
Yeah, we'd love to hear from the people using the tools and what the need for the tool really is. That would be helpful as well.
Wonderful. A question here about would it be feasible to have the tool link to regional geriatric programs for optional referrals? So adding a link to the tool so that it's easy to find the regional geriatric programs.
Yeah, I think that would also come down to when we come together to kind of brainstorm potential updates to the tool. I think that's where that conversation would maybe happen, ways to optimize the tool. So maybe something to think about in the future. So that's a great suggestion.
And so again, I guess it's, you know, as participants are thinking about its use and additions and things, we'll encourage them to email directly with their thoughts, suggestions. I see also another comment here about French Language Services Act in Ontario, of course. There are lots of services delivered in Ontario in French, and there's a mandate to do so. So it sounds like French is important to participants here. Dr. Freedman.
Yeah, and I mean, we're lucky in our family health team. We have someone who's very familiar with the IT part of REMR, but probably other people, you know, if you have someone like that, the tool can be customized also based on your settings. So I don't think there's any kind of trademark or, you know, so in our local setting, we've put in sort of our local resources within the tool. So I think people, if they put it in their electronic record, they could tweak it to suit their purposes. So for example, if you were in a setting where you had a specific referral pattern, say to RGP or another falls clinic, or you could put some kind of link within that.
That's great that it's very customizable. I think, and it would also be important too for people who are customizing still to also offer feedback in case it ends up being something that others are continuously adding as well, right? In case there's future updates. But wonderful that it's so customizable. What a great tool. Any other comments or questions from our audience? It looks like we'll be giving a little bit of time back, but we want to say thank you. And we also want to get just a little bit of feedback from the audience. I'm going to ask Melissa just to pop up a little poll with 2 questions, if you can take 2 seconds to answer. But thank you very much, Dr. Freedman, Lorna MacDougall, Makayla Gomes, for this really helpful presentation on such a fantastic tool and all the great advice and practical tips that you've given in terms of how to use the tool. Very much appreciated. Really glad to see this launched. Wonderful work.
Thank you so much for having us, and thank you for all who came out today. It's a great turnout.
Yeah,
a pleasure to be here and to see everyone. Thank you.